Good afternoon, everyone. I am Dr. Ravi Teja. I'm a consultant infectious diseases at KIMS Cuddles, Kondapur. Today, we are going to discuss about newborns versus superbugs, fighting infections in the first days of life. I'm a physician by profession. I'm not a pediatrician, but the principles of sepsis and managing infections in newborns and children and adults are same. I'll start off with two case scenarios. First case, this is a 26 weeks gestation age baby. Whose birth weight is 800 grams. Underwent a normal vaginal delivery elsewhere. Baby had respiratory distress syndrome requiring HFNC support immediately after birth. And the baby was diagnosed to be having pulmonary atresia with VSD. Over a few days, the respiratory support was worsened, and you have there that hospital they have suspected sepsis because of worsening respiratory supports and borderline hemodynamics, and they have started on antibiotics, piperacillin, tazobactam, and amikacin. And in view of worsening hemodynamics and oxygenation, they have referred to our center. The baby had a severe shock on admission, requiring ventilatory and high vasopressor support. So, what would you do? A 27 weeks gestation age baby who is extremely low birth weight is having severe shock on admission. So, you are a emergency NSU staff and the baby is front of you. So, what would you do? What would you suspect, and what investigations you will send, and what antibiotics will you give? So we have sent blood cultures on admission. So the baby in infectious diseases is always important to say your syndromic diagnosis. So what is the syndrome? Always try to uh, fit the child baby into a syndrome. Then only you can treat accordingly. So here the syndrome is a baby extremely low birth weight baby who is immediately post birth developed severe shock. So here the syndrome is septic shock, suspected septic shock. So suspected septic shock, we will immediately send blood cultures and start on antibiotics. Septic shock is an emergency. So we have sent blood cultures, and the blood cultures have flagged gram-negative bacilli in the early morning. The baby is admitted at night. Morning, night blood cultures were sent, and in the morning, the blood culture sent at night flagged gram-negative bacilli. And other investigations are as below. The counts are 53,000 with neutrophilic predominance, and there is a mild thrombocytopenia, and creatinine is normal, and LFT and electrolytes are normal. So, what would you do? The syndrome is suspected septic shock, and as we have expected, the blood cultures also have flagged gram-negative bacilli. So this is a confirmed septic shock with bacteremia. Source. So we have to identify what has led to this gram-negative bacteremia. So what might be the source of this infection? We thought the baby has baby has come from outside in other hospital, so baby has managed with central lines. So we thought the central line might be the cause of this bacteremia and septic shock. So we have initially started on polymyxin B initially. So this is a new PCR technology called blood culture identification panel technology. So here, what is the use of this blood culture identification is? we can identify the bacteria, the pathogen, either gram-negative pathogen or gram-positive pathogen within few hours. So this methodology will be very helpful to clinicians, uh, especially in this scenario where the baby is in severe septic shock, and we need to decide on our therapy treatment, appropriate therapy. The baby should get appropriate therapy as early as possible. Then only the baby will recover. Otherwise, it can lead to multi-organ dysfunction and probably death. So, in view of septic shock and blood cultures have flagged GNB, we have raised this blood culture identification panel, and the morning 8 o'clock blood cultures are flagged, and by immediately we have raised the BCID, and the report came in few hours by 5 o'clock. And as shown in this picture, so this panel has identified Enterobacter cloacae complex, and so gram-negative bacilli. What gram-negative bacilli has flagged, it has identified, and it also uh, helps us providing the resistance. The gram-negative bacilli carries what resistance genes. So based on that, we can give our antibiotic therapy. So genes detected are here: NDM is detected, and CTXM is detected. I will tell you about what is this CTXM and what is this NDM in coming slides. So to start with, this NDM is a carbapinamase resistance producing gene, and the CTXM is an ESBL gene. So NDM carbapinamase means this gene will lead to carbapinamase production. So carbapinams will not work. So meropenem, imipenem, metapenem, so all carbapinams will not work. And the CTXM means it is an ESBL gene. ESBL gene means this gene helps in producing cephalosporinases. So ceftriaxone, your ceftriaxone, cefporaxone, sulbactam, cefuroxime, all those cephalosporins will not work. So this report uh, helps us in exactly knowing what is the pathogen and also what resistant genes it carries. So it is a pathogen is Enterobacter cloacae. It carries both cephalosporinases and also carbapinamases. So those classes of drugs cannot be given. So the drug of choice for Enterobacter cloacae complex is ceftazidime, avibactam, and aztreonam combination. So colistin or polymyxin B can be given as last resort only, but the initial standard recommended drug is combination of ceftazidime, avibactam, and aztreonam. So our diagnosis: carbapenem resistance producing Enterobacter cloacae complex, likely from prior strain related. So we have changed therapy from polymyxin B to ceftazidime, avibactam, aztreonam in the same day within few hours, and the baby has responded very well. And in few days, baby was out of supports and is doing well. One more short case. This is a 20-day-old term baby, uh, normal birth weight, and baby had mild respiratory distress at birth, and baby also had an NICU stay for a few days post birth, and was discharged. Now baby presents to us with high grade fevers for 3 days and decreased feed intake. No other complaints. So what would you do? Baby comes to emergency. The parents bring the baby to emergency with high fevers for 3 days and decreased feed intake. So what would you do? Uh, so as I said before, you need to form a syndromic diagnosis. So here fever is more than 48 hours with no localization. So we can say it as suspected sepsis. There is no cough, no skin rash, no diarrhea, no vomiting, nothing else except fever. For more than 48 hours, we can say as suspected sepsis because of recent hospitalization also. The syndrome is suspected sepsis. So what we do? Suspected sepsis, we send blood cultures, and if baby is sick or a baby is having any organ dysfunction, we immediately start on antibiotics after sending blood cultures. So we have sent blood cultures along with some blood investigations. We showed 13,000 WBC with neutrophilic predominant and thrombocytopenia. Creatinine was normal. Urine analysis showed some mild pyuria, 20 to 30 parcels, and the CRP was 95. So we have also sent blood and urine cultures. So urine culture grew carbapenem resistant E. coli. Other sensitivities are amikacin is sensitive, fluoroquinolone and trimethoprim sulfamethoxazole is resistant. So what would you do? Actually, parents came to us with this carbapenem resistant E. coli report from done elsewhere. So what would you do? Do you give amikacin or what is your syndrome? Syndrome is suspected sepsis. So the source is here likely it is likely to be urinary tract infection. So baby is having fever. So it is a complicated urinary tract infection. So complicated urinary tract infection is our syndrome. So what drugs will work for this complicated urinary tract infection in empiric therapy, in directed therapy? So as we already got the report, so it is directed therapy. So what would you do? Do you give amikacin or do you give colistin or polymyxin B or ceftazidime avibactam ashunam combination, or would you say this is not UTI or this is some other source of fever? So what would you do? So we have sent blood cultures also. So blood cultures have flagged gram-negative bacilli. So now it is very confirmative that it is likely complicated UTI with bacteremia, gram-negative bacteremia. So what antibiotic would you start after this gram-negative bacteremia? Would you start an antibiotics or would you do BCID as in our previous case? BCID tells the pathogen and resistant genes also within 1 day. So do you advise BCID for this bacteremic baby also? So we did not. So the learning point is baby always look the clinical status of the baby. So in our previous case, the baby was in NICU, baby was on triple inotropic support, baby was on ventilator. So it is a severe septic shock baby where you have to decide your uh, empiric antibiotic or appropriate therapy within few hours. We cannot wait for more than 1 day in those very sick childs. So in that case, we have used the BCID methodology and we could tide over that sepsis. This child is admitted to the ward. This child is hemodynamically stable. Oxygenation, vitals are everything stable. So, and we also have a urine culture report where amikacin is sensitive. So we need not raise BCID panel. It is not required in this case as baby is hemodynamically stable, and we also have a culture report, urine culture report where aminoglycosides are sensitive, and you can save a lot of money in these scenarios. So we have started on amikacin, and baby was clinically little better, but blood culture also reported as the same pathogen, the carbapenem resistant E. coli. Also, it was the same pathogen in the blood also. So what would you do now? You continue amikacin or would you give colistin or what would you do? So as per recommendation, E. coli, any complicated urinary tract infection caused by E. coli, which is carbapenem resistant, The drug of choice is ceftazidime, avibactam, and aztreonam. Amikacin is a alternative therapy. When ceftazidime, avibactam, aztreonam is resistant, the synergy testing is resistant, where you cannot give ceftazidime, avibactam, aztreonam, then I would complete therapy with amikacin only. But here, as ceftazidime, avibactam, and aztreonam synergy testing is positive, means it will work. So the recommendation is to give the combination only. So we have changed it to amikacin to ceftazidime, avibactam, and aztreonam combination, and the baby is doing well. So diagnosis: complicated UTI, pyelonephritis caused by carbapenem resistant E. coli. So we have changed amikacin to ceftazidime, avibactam as per standard recommendation, and the baby is doing well. So before starting on this broad spectrum antibiotics to any neonate or infant, it's always recommended to know your hospital antibiogram. That is the first step. You ask me, like, I have to learn this antibiotic therapy. I have to my hospital I have to manage this complicated severe children. I would suggest first know your hospital antibiogram. Then only you can give appropriate therapy. Otherwise, it is impossible to give broad spectrum antibiotics, and it will not work also, because your pathogen is different. You are giving colistin or polymyxin B, but your ICU top pathogen is Enterobacter cloacae. So it will not work. So we think we are giving the broadest spectrum antibiotic. It should work for all gram negatives. It will not like that. It is not like that. So Enterobacter cloacae is uh, it will not work with polymyxins. So first you know your pathogen, your hospital antibiogram, then only you can give appropriate therapy, or it is also needed to give empiric therapy. So in this septic shock children, we cannot wait. We have to give empiric therapy, and your empiric therapy should be right. Your empiric therapy cannot go wrong. If your empiric therapy is wrong, then the mortality is high. So the first step is to learn your hospital antibiogram. So in a hospital, the antibiogram is the bloodstream infections. The most common isolate is E. coli, followed by Klebsiella and Staph aureus for bloodstream infections. So in my hospital, if any child or adult patient who is having suspected sepsis or septic shock, I would give empiric therapy covering the E. coli. I would not give empiric therapy covering Staph aureus. It is not required. The most common is E. coli. So this is the learning point. You should know your hospital antibiogram. You should know what is the top bloodstream pathogen in your hospital. Then only you can give empiric therapy and survival will be good. And in your hospital, urinary tract infections, the most common pathogen is E. coli, followed by Klebsiella. And skin and soft tissue infection, it is Staph aureus, followed by E. coli. And respiratory tract infection, it is Klebsiella, followed by Pseudomonas and Acetobacter. And resistance pattern in our hospital is ESBL enterobacterials is 68%. Carbapenem resistance is 11%. Carbapenem resistant Klebsiella is 53%. CR Pseudomonas is 26%. CR Acetobacter is 84%. So the importance of knowing your hospital antibiogram is of paramount importance. Without that, you cannot manage the sick neonates. So in your center, ask your microbiologist. The microbiologist will provide you this antibiogram every 6 months or every year. So please ask your hospital's microbiologist to provide this antibiogram to you. Then only you can manage, you can give empiric therapy to your sick neonates. MRSA is 49% in our hospital. So this is an article published in Nature last year. 40 million deaths by 2050. Toll of drug-resistant infections to rise by 70%. and by around 2050, around 2 million people, the majority around 70 could die from drug resistant infections each year. Not only elderly people, there are neonates, there are infants and children who are developing this multi-drug resistant bacteremias. Uh, so it is very, very prudent to learn about your hospital antibiogram and give appropriate empiric therapy to those sick neonates. So neonatal sepsis. The most serious burden bacterial infections are UTI followed by bacteremia and meningitis. So these are the commonest syndromes in neonates which we see in case of sepsis. So any neonates comes to you with features of sepsis or septic shock, these three syndromes should be in your mind. UTI for bacteremia or meningitis. Diagnosis and evaluation, you stratify by clinical features, age, WBC count, absolute neutrophilic count, and you perform urine analysis, urine cultures, blood cultures, and inflammatory markers like CRP and procalcitonin. So these, based on clinical features and evaluation, and your source and syndrome, you can and by knowing your hospital and antibiogram, you can give your empiric therapy in those sick neonates. Otherwise, you cannot do. So, etiologies of neonatal sepsis. There are two categories in neonatal sepsis: early onset neonatal sepsis and late onset neonatal sepsis. Early onset means within 1 week of birth is called early onset neonatal sepsis. The most common pathogen is Streptococcus agalactiae, group B Streptococcus, followed by E. coli, followed by Klebsiella, and followed by Enterobacter species. And lastly, Enterococcus species. Enterobacter is a gram-negative bacteria and Enterococcus is a gram-positive bacteria. Late onset, age 1 to 4 weeks of age. All the above pathogens 1 to 5 are also included in the late onset sepsis. Along with that, Haemophilus influenzae, which is a gram-negative pathogen, and Staph epidermidis in those with indwelling lines or devices, also pathogen in late onset neonatal sepsis. So in your hospital, any early onset neonatal sepsis, if your pathogen is E. coli, based on your hospital antibiogram, here the commonest pathogen is Streptococcus agalactiae, but it need not be the same to all the hospitals. This list will change based on hospital's antibiogram. So my hospital E. coli is the topmost pathogen, not Streptococcus agalactiae. So I will give my empiric therapy covering E. coli. I will not give my empiric therapy covering Streptococcus. Streptococcus is a gram positive. So E. coli is a gram negative. So there is a hell lot of difference in giving your empiric therapy. So it depends on your hospital antibiogram and knowing the syndrome and source. So this is a small article which was published in 2017. The article from USA. A clinical, is a prospective study published in JAMA. Is a clinical prediction rule to identify febrile infants less than 2 months of age and younger at low risk for serious bacterial infections. So here, any neonate coming with serious bacterial suspected sepsis and serious bacterial infections. What are the serious bacterial infections? As I've mentioned, UTI, bacteremia, and meningitis. These are the uh, top three serious bacterial infections. So this study group have tried to analyze, categorized neonates into high risk serious infections or not at high risk infections based on some blood markers alone. Uh, like this study, they have conducted in over 1,000 infants over 2 years who are coming to the ED. So they have tried to do urine analysis, absolute neutrophil count, and procalcitonin. So based on this simple blood markers, they categorized neonates into sick, suspected sick neonates and no sick neonates. So these tests help them to identify them. So they categorized so that they could act fast. Like if based on this criteria, if the child neonate falls into serious serious infection, they would start give blood cultures and empiric broad spectrum antibiotics you have to give, and you have to do lumbar punctures also. So those are very costly procedures. So by doing the simple small initial blood test, they were categorized into two, and further they would take call. So here the cutoff they have mentioned for absolute neutrophil count is less than or equal to 4,000 per microliter, and procalcitonin is 1.71. So anyone is positive, they would uh, evaluate the child as serious bacterial infection, and subsequently do blood cultures and antibiotics or lumbar puncture if it is required. If all three are negative, they would categorize child into non-sick child, and they would wait on that child. So by following this protocol, um, no bacterial meningitis is missed in this case study, but one infant with bacteremia and two infants with urinary tract infections were misclassified as non-sick child. So I would say these initial blood tests, I think it is done in all hospitals. Only procalcitonin is not regularly done. So procalcitonin can be useful initial blood marker uh, in the sick neonates. So WHO last year has proposed this bacterial priority pathogen list. So the WHO categorized bacterial pathogens into critical priority, high priority, and medium priority. The critical priority are carbapenem resistant Acinetobacter baumannii and third generation cephalosporin resistant enterobacterials. Enterobacterials includes E. coli and Klebsiella, the top two enterobacterials, and carbapenem resistant enterobacterials. These are the top three critical pathogens worldwide. And high priority commonly are the vancomycin resistant Ephesium, carbapenem resistant Pseudomonas aeruginosa, and methicillin resistant Staph aureus. So I'm sure every hospital, these are the top six pathogens. But what comes first, what comes second, what comes third depends on your hospital antibiogram. So my hospital, third generation cephalosporin resistant enterobacterials is the commonest pathogen. Uh, so that falls into critical priority. So know your antibiogram, know your pathogen, then only you can give your empiric therapy in those sick neonates. A few points about how to collect blood cultures. So volume of blood cultures is important, but not timing. So in neonates less than 2 months of age, we cannot use chlorhexidine or powdered iodine tincture. We have to use the alcohol-based rub with powdered iodine. Powdered iodine followed by alcohol-based skin antiseptics should be followed before collecting blood cultures. And catheter-drawn blood cultures have a high risk of contamination, false positives. So, prick samples are generally recommended. And do not submit catheter tips for culture, like centerline tip culture or drain tip culture is not advised. Never refrigerate blood cultures prior to incubation. And it's always advisable to send 2 bottles of blood cultures to identify the bacteremic load. Um, and streptococcus pneumonia and some other gram-positive organisms may grow better in anaerobic bottles than aerobic bottles. But in neonates and children, we don't have this aerobic and aerobic differentiation among blood cultures. So one pediatric blood culture bottle should be sent before initiation of empiric antibiotics. That is the minimum you can do. The screen got stuck. 1 minute. Um, the next is this beta-lactamase classification. So this thing should be known to everyone. This is beta-lactamase classifications. We have classified the enzymes. As I have said before, the CTXM enzyme, NDM enzyme has 4 different classes. We have Ambler class A, class B, class C, and class D. The CTXM, in case 1 we have seen, this yellow one, this is CTXM, it is a cephalosporinase. It comes under ESBL producing enzyme. And the NDM gene, it comes under Ambler class B, it is a carbapinamase. So we have other this ESBL genes and carbapinamase genes. The other ESBL genes include TEM and HSV, including CTXM. But in our India, the most common ESBL gene is CTXM. And we have many carbapinamases. The most common in India are NDM carbapinamase, which we have seen in our first case, and OXA48 is the another carbapinamase which is most common in our country. So there are many other carbapinamases like KPC, VIM, IM, GIM, and OXA23. So these are not commonly seen in our country. They are seen, KPC is most commonly seen in US. So based on your area of practice, you have to know which gene is most common. So, but throughout India, NDM and OXA48 are the most common carbapinamases which we see. And the class is class C, it is MC. It is also an separate class of beta-lactamases. It is a separate topic. So it is not commonly seen. There is a guideline from Infectious Disease Society of America, which published last year about treatment of antimicrobial resistance gram-negative pathogens. So as I've said, non-susceptibility to ceftriaxone is a marker. When anyone sees a culture report, when you see ceftriaxone is resistant, you can say it is an ESBL pathogen. Suppose you see an E. coli urine culture report which shows ceftriaxone as resistant, you can say it has ESBL producing E. coli. So there is no methodology in the lab to check for CTXM gene as we have done in our BCID panel. In normal patients, you can't do BCID or check for CTXM genes. So this ceftriaxone resistance is a proxy marker to say that E. coli pathogen is producing ESBL enzymes. So cephalosporins cannot be given. When ceftriaxone is resistant, it is an ESBL producing E. coli, and you cannot give other cephalosporinases like ceftazone, sulbactam, cefixime, cefuroxime. All those will not work. First generation, second generation, third generation cephalosporins will not work. So recommended drugs for this ESBL producing gram negatives are piptaz, piperazine, tazobactam, carbapenems, trimethoprim, sulfamethoxazole, fluoroquinolones, and aminoglycosides. Based on the severity of sepsis in your neonate, you have to take call what to start. Whether to start IV piperazine tactobactam or IV carbapenem, or oral trimethoprim is enough, or oral fluoroquinolones are enough, or IV aminoglycoside I have to give. So based on your uh, sick child, you have to take your call what I have to give. Non-susceptibility to carbapenems is a marker for carbapenemase production. So I've told you the NDM, OXA48, KPC, they're all carbapenemase genes. So this can't be tested in lab except on the BCID panel. So in any report, culture report, you see it is a meropenem resistant or meropenem, imipenem, metapenem resistant E. coli. You have to say that it is a carbapenemase producing E. coli. You cannot give carbapenem. So if meropenem is sensitive, imipenem is resistant, there's nothing like that. This is a wrong report. You can't tell one class within the same class one drug is antimicrobial is sensitive and another is resistant. So recommended available drugs for carbapenemase gram-negative pathogens are ceftazidime, ibactam, and astronam, polymyxins, phosphomycin, tetracycline, minocycline, aminoglycosides, fluoroquinolones, and bacterium. So you cannot give what all this class of antibiotics. So you have to know your syndrome, whether it is bacteremia, whether it is UTI, whether it is pneumonia, or it is skin and soft tissue infection caused by the carbapenem resistant pathogens. Then only you have to see which antibiotic is the correct choice for the source. I will explain about where to use TG, where to use T-cycline, where to use ceftazidime avibactam as shown. So whenever possible, transition to IV oral therapy can be considered when, particularly when following four criteria are met. So any sick neonate comes to you. Generally, this applies to children and adults. Neonates generally we don't start on oral therapy initially because they're already on feeding and all. So for children and infants, we can use this criteria. When susceptibility to oral agent is demonstrated on the culture susceptibility. Like if any fluoroquinones or bacterium is susceptible, then you can change to oral agent. Or if the child is hemodynamically stable, initially child presented with shock, then shock has resolved, the child is shifted to ward and absolutely hemodynamically stable, then if oral agent is susceptible, then you can give. Or source control have occurred. So there is no problem with source, like any line is there or any abscess is there, then you can't switch to oral antibiotics. Or there should not be any concerns about intestinal absorption, any ongoing diarrhea. So in those scenarios, you can't switch to oral agent. So all these four criteria have to be met. Uh, then only you can switch to oral antibiotics. So based on high bioavailability and high serum concentrations, trimethoprim, sulfamethoxazole, and fluoroquinolones are the best agents for considering treatment of ESBL equal enterobacterial infections. And clinicians should avoid oral step down to nitrofurantoin, fosfomycin, amoxicillin, clavulanic acid, doxycycline for ESBL producing infections. So ESBL producing infections, amoxicillin, clavulanic acid will not work. Doxycycline will not work. Nitrofurantoin and oral fosfomycin will not work for bloodstream infections. You have to. You have only two options: either trimethoprim sulfamethoxazole or fluoroquinolones. So here nitrofurantoin for oral fosfomycin achieve poor serum concentrations, so they are not recommended. Amoxicillin, clavulanic acid, and doxycycline have limited data to support their efficacy in ESBL producing bloodstream infections. So these amoxicillin, clavulanic acid, doxycycline are also not recommended for bloodstream infections. So, about IV fosfomycin, oral fosfomycin. So any bloodstream infection caused by carbapenem resistant enterobacterials, either E. coli or Klebsiella, we can give IV fosfomycin, but only in children, not in neonates. So one of doctors asked me like, we have given IV fosfomycin for a child, then can we switch to oral after a few days? So both are fosfomycin only. So why can't we give oral instead of IV? It will be easy, doctor. So the concept is of this bioavailability and is not there for this oral fosfomycin. So oral fosfomycin cannot be given in case of bloodstream infections. And oral fosfomycin also will not acquire oral doses. And there is also a concept of phos A hydrolase gene in case of Klebsiella, where IV fosfomycin can lead to failure, clinical failure in few cases. So you have to be very careful whether it is what is the pathogen, whether it is E. coli or Klebsiella or Acinetobacter, Pseudomonas, Enterobacter. So the identifying the pathogen is very crucial. So what I have few questions. So what is the role of combination therapy for treatment of infections caused by carbapenem resistant enterobacterials, that is E. coli and Klebsiella? So the child, the neonate child is very sick. Can we give two antibiotics? It's a common question we face. Can we give IV ceftazidime, avibactam, and astronam, and also polymyxin? Neonate is very sick. Can we give both? So the standard recommendation is combination antibiotic therapy is not suggested for treatment of infections caused by carbapenem resistant enterobacterials. So you have to choose your therapy rightly. Choose your empiric therapy rightly. There is no role for combination therapy. uh, Whether there's a role for inhalation of antibiotics in respiratory infections caused by this multidrug resistant pseudomonas or carbapenem resistant Astrobacter baumannii. So as per this last year IDSA guideline, uh, those guideline has checked all the randomized control trials, all the available studies, and they have said that they do not suggest the use of nebulized antibiotics for treatment of these respiratory infections. And based upon number of RCTs, they have concluded that there is no survival benefit, or there is no reduction in ICU stay, or there is no reduction in ventilator days observed in patients or neonates who received nebulized antibiotics. And there's also concerns about unequal distribution in the infected lungs and potential for respiratory complications such as bloodstream bronchoconstriction. So you must have seen like neonate is getting inhaled colistin or inhaled polymyxin. So you must have seen in your ICU. So this is not recommended. So based on available studies, inhaled antibiotics will cause more harm than doing better. And few words about tetracycline. It's a tetracycline class, and it is can be considered as an alternative option for intra-abdominal infections, skin and soft tissue infections, osteomyelitis, and respiratory infections caused by carbapenem resistant gram-negative pathogens. So tetracycline is never an empiric choice. It is a reserved drug. Tetracycline, there we have only few carbapenem resistant treating antibiotics. So tetracycline is one of them. So it should be used only when you isolate a carbapenem resistant bug. It is not recommended for bacteremia and complicated UTI. It is only recommended for skin and soft tissue, intra-abdominal infections, osteomyelitis, and respiratory infections, where you isolate a carbapenem resistant gram-negative pathogen. No. And does not acquire adequate serum levels in the standard dosing. So why, you can ask me why T-cycline is a carbapenem resistant antibiotic. So why can't it be used for bloodstream infections? Because IV T-cycline will not acquire adequate serum levels at standard dosing. So it is generally not recommended for bacteremias, not recommended for bacteremia or bloodstream infection or complicated UTI. And Pseudomonas aeruginosa is a gram-negative pathogen, is intrinsically resistant to tetracycline. So any Pseudomonas intra-abdominal infection, you can't carbapenem resistant Pseudomonas, you can't give tetracycline because it is intrinsically resistant. So there are many small details like any carbapenem resistant GNB, we can use tetracycline intra-abdominal infection. So no, we can't give like that. So if it is Pseudomonas, you can't give tetracycline, it is intrinsically resistant. So how will you know whether you can give or not? So as I've told, the first step is know your hospital antibiogram. Then only you can prescribe your empiric therapy. The field of AMR is dynamic and is rapidly changing, and this multi-drug infections will continue to challenge all the clinicians as newer antibiotics against resistant pathogens are incorporated into clinical practice. We are learning more about their effectiveness and propensity to resistance. So down the line, these gram-negative pathogens can develop resistance to, say, T-cycline. So few years down the line, T-cycline may not work. So T-cycline resistant gram-negative pathogen can emerge at any time, or phosphomycin resistant gram-negative pathogen, or ceftazidime avibactam ashunam resistant E. coli. So already they are about 20% of, as per the data, around 20% of E. coli isolates in our country are resistant to ceftazidime avibactam and ashunam. So these percentage might increase in future, and we are at dire need of newer antibiotics. So to preserve these antibiotics, you have to know your hospital antibiogram and give appropriate therapy. So few take home points. So as I have told and I will tell again, the first step in learning about giving this empiric antibiotics in your sick neonates is to know your hospital antibiogram. Then only you can prescribe the empiric therapy and your neonate or your child will become better. Otherwise, the empiric therapy is wrong, then the child will not get better at any time. Whatever antibiotic you give polymyxin and vancomycin. If your pathogen is like, as on our first case, it is Enterobacter cloacae, both your polymyxin, both your vancomycin, or you give tigecycline, whatever you give, it will not work because the right drug is different for that Enterobacter cloacae. So knowing your hospital antibiogram is the first step, is what I would suggest. And bloodstream infections are a medical emergency. Use of rapid identification methods like MALDI-TOF and BCID helps in early identification of pathogens. So when it is available, you can perform this test. When it is not available, you have to know your antibiogram. That is a simple test. So if you know your antibiogram, then this BCID and MALDI-TOF may not be required for you. If they are available, you can use it because you can tailor the antibiotic appropriately. You can stop other antibiotics also. So in our first case, we have stopped the colistin and we changed to ceftazidime embark. So it helped us preserve other broad spectrum antibiotics. So whenever it is available, we can use in sick neonates who are in NICU on triple inotropes. So these tests should be used. So the right drug for the right clinical syndrome is very crucial. So as I've said, tigecycline will not work for bacteremia. Tigecycline will not work for complicated UTI. So like in our second case, we had uh, carbapenem resistant E. coli. So can we give tigecycline? No. The report will say as tigecycline sensitive. So but we cannot give tigecycline because it will not work for complicated UTI. Even though it is a carbapenem resistant treating antibiotic, you can't give tigecycline because it is not the right drug for the right clinical syndrome. So knowing the right drug for the right clinical syndrome is also very crucial. And antibiotic stewardship, antimicrobial stewardship is a way to prevent this rising MDR infections. So you have to be very careful about prescribing these antibiotics. You have to be very careful in de-escalating also. Once you know the pathogen, once you know the syndrome, then you know no point in continuing other antibiotics. Like for example, if a child is on child neonate comes with septic shock and you identify uh, carbapenem resistant E. coli and it is ceftazidime avibactam synergy positive, so you can give ceftazidime avibactam. You need not give other uh, gram negative cover. You can stop meropenem, you can stop colistin, you can stop other gram positive cover like any gram positive cover that the neonate is on. You can stop those also. When you're really sure that that is the only pathogen which is causing the problem. Thank you. There be any questions? To the chat box. So any questions the participants are having can post in the chat. Thank you.